Hello, everyone. We're going to try to go through this quickly because I know you all have things to do on a Friday afternoon. I'm Dr. Debbie Daniel. I'm the family practice doctor. I've been doing it 35 years. I have two offices, one over in Dunlap. It's a traditional fee-for-service office. We answer to Medicare. We are compliant. We like our scores. My other office is DPC, downtown Chattanooga. What is that? It's basically affordable concierge. We don't take insurance. We don't answer to Medicare. We do what the patient wants. But we're here. Tracy called me and asked me to speak on compliance, and I said, how come I get the hard part? But Tracy's wonderful, so it's hard to say no. So here I am talking about the impossible. Dr. Lazar does stents. He makes people better, and they want me to tell you how to make your patients compliant. What do we mean by compliant? I look at compliance, most doctors do, as a patient comes in, they got a problem, we look at it, work it up, give them a treatment plan, some advice, they follow it, everybody, they get better, we're all happy. What's Medicare called compliance? Medication adherence. Is anybody, sorry.
Hamilton.
Sorry. Anybody have any idea how many patients are adherent with their medications? I met with Blue Cross this week. I have 17 out of about 225 Medicare Advantage patients that are non-compliant. That means they have less than an 80% compliance rate. Why do I care what Medicare says? Because they pay me based on that. So fee-for-service world, I'd better be paying attention to that stuff. I'll give you an example of the best and worst compliance in one person. My grandmother at 61 lived in West Virginia, had a heart attack, went to the Mecca, Cleveland Clinic, and had quadruple bypass, had a blood transfusion, got hepatitis. They discharged her on the little blue pill, and this was her compliance rate. For the rest of her life, she always took the little blue pill from the Mecca. She was sick, weak, and dizzy the rest of her life, and she would take whatever of her other medications or my grandfather's that she thought would make her feel the best that day. For real, that's what she did. 5 years later, she had her second bypass because she still cooked with lard and all that good stuff. 20 years after the first bypass, she got her carotid arteries done. And my aunt called and said, she did great with surgery, they can't get her out of ICU. What's the problem? Her heart rate's 38. And I ended up going up there, and of course I'm nosy, so I'm in the unit, looking at her chart, talking to the nurses, and I'm like, her heart rate's 38, why is she on atenolol? That's the little blue pill that the Mecca gave her that she would take. Well, we're gonna stop the atenolol. She got out of the unit, she went home, she went back to the little blue pill that made her sick, weak, and dizzy. But that's what we deal with as primary care every day. People have talked about helping their patients understand. But when I talk about patient compliance, to me it's kind of simple. Everybody's got intelligent patients that understand their disease process. They've researched their medicine. They're the jewels. They go out for a walk every day. They don't drink. They don't smoke. But most of our patients aren't perfect like that, but I need them to have an acceptable level of engagement with me, cooperation with me. What does that mean to me? Last week, I'm driving my car, and when I turn it on, it says maintenance coming up soon. So I called Kayla, scheduled me some maintenance. I took it in. I understand I need to change the oil, keep air in the tire, so my car will last longer. I don't care how my engine works, don't care at all. I just want to know that it's going to last. My heat and air, my guy tells me change your filters once a month and let me come by once or twice a year and do routine maintenance, and it'll last longer. So I'm engaged to that. I don't want to know anything else about it. So that's what my vast majority of my patients come to me for. I help them know some about diabetes. Diabetes is complex. So they need to know how bad sweet tea is for them. They need to know their medications. And again, we ask things like, we got patient assistance. You know, some of the programs are very generous. And sometimes like they say, you feel a little uncomfortable, but do you make less than this? Because we can get you some assistance. So those patients, we tell them, we got to get your LDL to this. We want your blood pressure at this. We want your A1C. We got to get your diabetic eye exam. We got to do a colonoscopy. Yes, you need your mammogram. And so what do we do with this gentleman right here that says, I don't want to do that? They're discharged, period. You know, I'm 62. I'm too old for it. I'm scored by Medicare. So if I have a patient, a new patient, and occasionally, not very often, but sometimes the very first office visit, I terminate that time. You're wasting my time. I'm here to help. You don't want help. I've been to therapy. I know I can't save the world. I'm only here to help the ones that want help. So if you're going to be a drain on me, you're no longer my patient. So I have a patient come in and they got an A1C of 12.9. They get to come back in 2 days and we put them on a plan and we'll see them every week. But I tell them in 90 days if their A1C is not below 9, they're gone. I've done it too long. I'm going to help the people that want help. And if people really want to do it and you spend some time, they can get there. But if they are not engaged enough in their own health, I don't have time for them. They're going to make me look bad. They're going to frustrate me. So we just discharge them. So that's kind of a very blunt. I think we do great primary care. You know, we do great primary care, but I'm just too old to take care of the people that don't really care. So that's how I deal with compliance. The other thing I do deal with is, I was thinking about talking about this, and I just 4 people's names popped in my head, because, you know, I do put myself in theirs, and, you know, I thought about 4 patients, and I pulled their prescription list, and sometimes when I come in, a new patient, and they're on this many, I go, wow, you think we could get you off of? Sometimes when they're on so many medicines, they're resistant. Oh my God, don't take one away from me. I've got a paranoid schizophrenic, he's on 12 meds, 4 to keep his schizophrenia under control. His wife is on 20 different medicines. Is anybody in here able to take 20 medicines accurately, to know which ones you take with food, without food, you know, which ones go together? I mean, come on now, you're asking a guy that you know, changed the oil all his life to take 20 different medicines correctly. I've got an amputee, of course, he's got peripheral vascular disease. He's on 16 meds. He's got dementia. How easy is that? I've got another one with coronary artery disease, COPD, continues to smoke 2 packs a day. He's on 17 meds. So, you know, I do look at the polypharmacy. I look at how we impact their ability to be compliant. The best gift is my staff. My staff loves doing what they do. They love our patients. So that's how we run it. We love our patients, and if they want to get better, we're the right place for them. But if they have no interest in getting better, it's a very short relationship. So that's all I got. Thank you.
Managing patients is an absolute art form, and they're just challenging. I always find that sometimes you have to help them first before they actually start to believe in you or trust in you, and that's usually kind of how I try to focus on some of these really tough ones. But definitely lots of styles and lots of ways of handling things. So I want to just talk a little bit about you know, networking and with the subspecialties and primary care, and really kind of how I see this working. Critical limb ischemia, you've seen this before, represents the final stage of PAD progression, and amputation is often the outcome. And I think there's some amputations out there that are, I would call, inappropriate amputations. Not that people are doing things that are wrong, it's that there may be a better way of doing things. And I'd like to explore that a little bit in the community. So how do we as a medical community get ahead of and manage this disease process for our patients? Well, if we kind of work on individual islands, podiatry here, wound care here, and vascular here, we're not going to do a very good job. We won't be effective at actually changing and implementing a policy of care for a region. So I really think that you have to have, surround the patient with the right kind of doctors who take care of that problem. So when it comes to a patient with critical limb disease and they land within the circle, they're going to be touching one of these doctors first. Some of the one service first. Maybe it's primary care, maybe it's podiatry, but we need to activate the people that actually can start to help the patient. So, a critical limb patient with a sugar of 500, it doesn't matter how well I do the Roto-Rooter, that's not going to fix the problem until I get them to their endocrinologist and we deal with that sugar and deal with that problem. And so same thing if there's infection. So if you have to get the patient to the right physicians to care for that overall patient to actually achieve limb salvage. And so if we have, this problem of in the South, I think that, working together is the only way to actually handle this. So this patient that I showed before, diabetic, wet gangrene, we reconstructed the arteries and she got better. So we know that we can do this now. We know that we have a high rate of success doing this. And, are we on a pathway to limb salvage in the U.S.? I would say no, we're still on a pathway to amputation in the U.S. And the major amputation most often is the only treatment option offered to CLI patients. No attempt at revascularization in 60 to 70% of CLI patients, and no angiogram performed in 51 to 73% of patients with CLI disease, despite a 90% chance that you're going to reduce a need for an amputation. And so this doesn't make sense. If we kind of know some of this stuff, then why is it still happening? And I think there's just a time for a change. We need to have a different change in the philosophy. And so instead of, a hospital consult now for Dr. Lassar, please perform an amputation on this patient. All of these patients were recommended to have amputation. It may be, consider revascularization on this patient, thinking about it that way. Advanced elderly does not necessarily mean that amputation is the best option. Maybe a very simple endovascular procedure can solve the problem, and I don't have to amputate a 129-year-old patient's limb. She had it for 129 years. I want to let her keep it. So that should be our goal. Contractures, sometimes we think, okay, well, you have a severe contracture, you really can't walk. But that man in the middle there, he is standing, he is walking, he's trying to move. And whatever we can do to encourage mobility is actually critical. I'm not saying that you shouldn't do amputation ever. These are patients who have osteomyelitis, the joint's destroyed. There's, the bones are exposed in that bottom picture. I can't save that. We can't save this. The best thing to do is an amputation to get them to try to move, a below-knee amputation. And there's some thoughts that maybe amputation costs less than endovascular therapy, but actually amputation costs more than either bypass or endovascular therapy. And it has a lot to do with the fact that they have to have a wheelchair and ramps built and new things put in their house so they can move and travel. And so there's a lot to it than just simply a simple surgery. Endovascular or the OBLs, where we do a lot of our work in outpatient environment, is actually probably cheaper. So we're trying to drive cost a little bit down by doing some of the work that way. So I think the surgical mindset must change. Surgeons like to operate, and we operate depend on our levels of training. If we are if we're trained how to do the FemPop interventions or tibial interventions or pedal interventions, then you're going to be more successful. General surgeon knows how to do this operation. So if they need a tibial operation or a pedal operation, then that equals an amputation because they can't do that. A vascular surgeon might know how to do tibial, like a tibial bypass, that's part of their training. But pedal circulation, it's very rare to have someone working below the ankle. That's something you have to learn or be trained to do. And maybe a critical limb specialist, like many of the doctors that we heard today, I think they have all the tools to actually try to prevent the amputation. So they have the tools to do this. So access to care must change. And there's a great little study. It was over here in North Carolina, and they looked at all the patients who had amputations in their different counties. And in the gray areas, in the darker gray areas, these are areas that have either no physician, no surgeon, or no vascular surgeon. So the areas where there's a dot is where the vascular surgeons are. And if you lived in the wrong county, you had a 30% higher chance of losing your leg just by living in the wrong county. So this has a lot to do, access to care has a lot to do with what happens in the area. So patient-associated factors have to change. The smoking needs to be addressed. The obesity epidemic is real, and it is only getting worse. And it plays a role in diabetes. And as we develop more type 2 diabetes, we tend to have more problems that we've discussed with the podiatrist today. The atherosclerotic timeline, we will tend to calcify as we get older. And can we avoid some of this endothelial dysfunction by maybe eating well and being more active? I think those are the things that can actually lead us in the right direction. And so if we can identify disease just a little bit faster within the community, then we actually have a chance of trying to impact outcomes. We think that about 80% of all patients with PAD in the US just are not diagnosed and therefore are not being treated. So they will be the ones in 20 to 30 years that have the advanced disease. And so if we're going to actually impact some of these patients, it has to be in the primary care area, and it has to be where we impact them early in the process. So how do we, as a medical community, get ahead of and manage this disease for our patients? Well, it's a network that we have. Maybe it's a loose network. You know, it's not a Mayo Clinic where we have 5 doctors surrounding the patient, but I know every one of you, and you guys know us, and develop your own networks for how you think about disease and patients. And then as you start doing that, you can start adding the specialties to effectively take care of those patients. I think promoting a sense of urgency for PAD is important, and I love this from Erlanger. I'm not sure who thought of this, but it's kind of like the mind is melting away, and this is, you know, how do we think about stroke? Well, you're having a brain attack, you know, just like you have a heart attack. You know, if you have come into the chest or to the ER with chest pain and troponins that are elevated, you're heading towards that cath lab, and within 60 minutes, you're going to have somebody looking inside your coronary artery. Well, that's amazing. We think about stroke the same way, but we don't think about the foot the same way. And so I think you have to think about this as we're having a foot attack. Ischemia is non-selective, and time is tissue. The longer the time this is ischemic, the less chance we have a chance of fixing it. So if people have flow problems, feeling of pain, loss of sensation, open sores that don't heal, or weakness when they walk, if they have a flow problem, then they really need to be evaluated by a vascular team that does that. I think if we can surround the patients with the right doctors, we can successfully provide limb salvage, and we know that if we keep their leg, keep them walking, we can improve their survival. And so then there's secondary prevention. Once we have saved the limb and gotten out of the problems, why do these people die? Well, they die of their heart disease. And so cardiology consultation, making sure they really don't have obstructive coronary disease, making sure their carotids are clear, those are the things that you have to do for secondary prevention. Working together as a team is really the only way to handle a lot of these patients. If we're going to make an impact on these patients over the next 20 years, 30 years, or on our community really over the next 20 to 30 years, then we're going to have to work together. So no more amputation. Thank you all for this opportunity to speak with you all today. So I've asked a very special lady in this community to close our session. And Ray Bond is familiar to many people in this room. She's the Chief Executive Officer of the Chattanooga Hamilton County Medical Society. I think she's been there longer than I have been here in this community. And she is a steward of grace for this community. She is a fighter for legislative control for our medical society. She's received many different awards. She's the champion of healthcare, a Lifetime Achievement Award in 2020. She's had the Athena Award, Chattanooga Women of Distinction, and she's just recognized for her community service. and I wanted to have her at least close today and talk a little bit about the things that she's doing and community awareness and involvement in what's happening currently. Ray?
I appreciate it.
You are welcome. There's your clicker.
I want you to know I had to work really hard to get the cherished 4:15 speaking spot on the second day of an intense conference. So I shall try to be up to the task, but also really brief. So I'm probably a different from all of you because I was an English major, and then I was a journalist, and then I was in politics, which actually today makes it perfect to be working with doctors and in medicine. So the Lassars asked me to talk a little bit about leadership in community health improvement. And so if you can, are you gonna, do I have the clicker? I have the clicker? There's such power with the clicker. So organized medicine, physicians have got an interesting, you think about doctors and you think about advanced practice professionals and all the folks who work in the healthcare community, and you think about the medical stuff. But really, all of those health professionals have had a really powerful impact in our state for many years. And in 1830, and this was a time when if you spent a little time studying with a barber, you could hang up your shingle as a physician, because apparently they had the tools to inadvertently or intentionally do bloodletting. And so in 1830, the Tennessee General Assembly created the Tennessee Medical Association to improve the conditions in the practice of medicine, to develop public confidence in the profession, to stimulate constructive inquiry into medical science, and my favorite, to suppress quackery. And I stand firmly for all of those things today. So the efforts that they started with included training requirements for those who called themselves physicians. And the nursing boards have done the same thing for those who call themselves nurses or advanced practice professionals or physician assistants. And so those efforts led to creating the training requirements. And also, organized medicine in Tennessee had a huge role to play in the formation of the Board of Medical Examiners. Now, if you've ever been before the Board of Medical Examiners, that may or may not be a good thing. But largely, the Board of Medical Examiners is the thing that establishes the standards, interprets the rules and regulations that are going to impact how you practice medicine. And then our medical society, locally, we were started in 1883, and contrary to rumor, I have not been there since that time. I've actually been there 23 years in 2 different stints. I was there for a few years, and then I came back, go figure. And our goal is twofold: to support physicians in practice of medicine and to improve community health. Those were the goals in the beginning, and those are the goals today. So we've had a long tradition. The physicians in our community have had a long tradition of community service. And I think this is a really important thing sometimes, to just take a moment back and see where you've been, because sometimes that'll help you cast a vision for where we want to go next. So in our tradition of community service, we've been involved in things on preventive medicine, public health, smoking, environmental issues, infant mortality reduction. A few years ago, our infant mortality rate was worse than Memphis's infant mortality rate, and I just couldn't imagine that, but it was true. So we got to work and did a lot of really positive things, including changing some hospital guidelines, and that rate has improved very significantly. And then a few other things that we've done, oops, go back. In the 60s, the Medical Society and a couple civic groups got together and formed a blood procurement committee that a few years later became Blood Assurance. And so all of you in healthcare understand how important that is. And that's a case when doctors were casting a vision to think about how to help a problem with the whole community, how it impacted all of medicine. And that's part of what the Medical Society tries to do. We try to think about how to make practice better for doctors, and we try to think about how do we make things better for the patients. We also, in the 70s, we helped vaccinate 35,000 children against rubella. And in 2006, workforce is a huge issue for us, and I thank each of you for choosing a career in healthcare. So in 2006, we began a Future Doc program, and a couple of you I know have done shadowing for us. We have trained about 450 high school students, and many of them are now in careers in medicine. They're in residency, they're in medical school. Some of them have become nurse practitioners. One wonderful student from one of the early years is finishing her MD, PhD simultaneously in Chicago. I think she's an overachiever. So we launched in 2012 the Future Docs program, and that's a program for college students to do intense shadowing for several weeks to help them really focus on what kind of health professional they want to be. And I don't know if you know about, the last few years have been very intense in medicine, especially around the pandemic. The Medical Society played a major role throughout COVID. My refusal skills really suck, and so that's how I ended up chairing the city-county COVID task force the first whole year of COVID. It was a magical experience in which I was called names I'd never actually heard before. But most people were really thankful for getting scientifically based public service announcements out regularly. And the Medical Society came together and did things looking like, what are the ethical standards? If we ended up a real crisis with shortages of medical equipment or medications or beds, what are the ethical considerations? And so the 3 hospital systems came together with us and helped develop some criteria. We did that very quietly, but it was a really important thing that gave physicians at each hospital a little bit of certainty as they plowed into something that most of us had never experienced, because it's been a long time since we've had that kind of pandemic. Burnout has been a big issue, so in 2019 we started the LifeBridge Physician Wellbeing Program. We do educational programs and conferences. We have a hotline, and we provide counseling resources with counselors who've been vetted and understand what it's like to practice medicine, and who've had some special training. And so we've had more than 60 doctors who've taken advantage of that, because when you lose a doctor before the logical time they're going to leave medicine, it's a huge cost to the health system, and it's a huge cost, and frankly, we have such a shortage of healthcare providers in every way. We can't afford to lose anybody early. We just can't. And most importantly, to me, a few years ago, we lost a doctor in Chattanooga to suicide. There's been more than one doctor we've lost to suicide. And to me, that is absolutely unbearable, because sometimes I've known those folks. And they're wonderful human beings who needed the right kind of help at the right moment. And so that's what the LifeBridge program's all about. We also know that food and nutrition is a really important issue. We have food deserts, that's a huge problem, and we're looking at a food desert kind of in our footprint. So we helped get the Brainerd Community Food Pantry started 2 years ago. We gave them the startup funding from our foundation to do that. But the biggest thing we've done in public health is Project Access, and Dr. Lassar, many of you have been part of that since the very beginning. In 2002, Dr. Joe Kofer, who was a surgeon at Erlanger, was operating in the middle of the night on somebody who presented to the emergency room in really bad shape, and he was uninsured. And Dr. Kofer walked away from that saying, you know, he wouldn't have gone to intensive care, he wouldn't be this sick if he had gotten help earlier. And so Dr. Kofer came to the Medical Society and said, we need to fix that. And the solution that he found, and that I was privileged to help start, is Project Access. Project Access is a coordinated specialty care network for low-income uninsured folks. People think TennCare covers everybody. It absolutely doesn't. If you don't have the right disease, the right family status, the right circumstances, you're just out of luck. And so Project Access is really designed to try to help the working poor and let people go back to work, continue supporting their family, and to provide care before they reach a crisis and the emergency room. So in 2019, we had 32,303 Hamilton County residents who were uninsured. 74% of them lived in family households, and 71% of them were employed full or part-time. But a lot of them were employed in 2 part-time jobs, 40 hours or more, minimum wage, never qualifying for any workplace benefits. So, Project Access is a clinic without walls. It's the coolest thing. We coordinate health care for low-income uninsured patients by organizing physician volunteers and other partners. All the hospitals participate with us. We get referrals from 14 different community health centers here in Hamilton County. And this last year and a half, we've been working to expand a little bit regionally. There's a huge crisis in access to care in rural areas. And so the State Department of Health has asked all the Project Access programs in Tennessee to try to help with that. And you know, the thing is, doctors and hospitals have always provided charity care. You all know that. You've had patients who lost their insurance. You kept taking care of them. Hopefully they were able to get better and go back to work and get insurance, and you'd continue to take care of them. But it's what doctors and hospitals have always done. But Project Access lets you refer to us. It lets us connect a patient with a specialist. All the hospital systems in the region participate with us. And so it's really a wonderful thing because it lowers cost, it equitably distributes care between the hospital systems, and there's some beautiful, beautiful stories. And if it weren't 4:30 on a Friday, I would tell you some of those stories. But we've saved people's vision, we've saved people's limbs, we've saved people's lives, and most of them have been able to go back to work and continue supporting their family. It's really incredible. This is our little flow chart. I think it's really impressive. You can just see all the boxes. Those are all partners, and that's how we find people. It's how we get them through the system and hopefully get them on to healthier and more positive, productive lives. So, since we saw our first patient in April 2004, we have coordinated $219 million of donated healthcare services. We have had, on average, a 20-to-1 return on investment. Every dollar we spend on care coordination and physician recruitment and patient education and economic validation, all that has generated between $10 and $25. It varies a little bit based on what program stage we're in of care. Right now we have 1,150 physician volunteers and many nurse practitioner and PA volunteers. We've provided services and care to 23,500 people in that time. We have about 500 patients enrolled every month, and we care between 3,000 and 4,000 patients every year, yeah. So the benefits are, it engages more people providing charity care. We can ask a doctor, in this next year, could you take care of 6 or 10 patients? And most will say, yeah, I can do that. We rotate through the systems. We keep people connected to their primary care home. It has a real positive impact on their patient health. It documents our results. It improves patients' health status. It has lower ER use. It's cost effective. But the most important thing is just a compassionate way to do it. A lot of our patients go on and they do become insured. Some are able to go back to work and eventually get health insurance. Some of them reach 65 and qualify for Medicare, but we have a lot of patients over 65 who don't qualify for Medicare. A lot of them have fewer limitations. It's just a great thing. As I said, we also care about, when we think of community health, I think of physician health a whole lot. And someday I hope that we have the resources to think about PA and nurse practitioner health, because I think those are all equally big issues. You all have the same pressures. So we did start LifeBridge, and we have just launched the Mayo Clinic Wellbeing Index as a new resource. And in that, doctors will get a periodic email from us, and they can take about 6 minutes, answer some questions, and say, I may not be doing so well. What should I do about that? And to cause a moment to think or reflect. Or maybe you've been trying some new things, and you do the survey, and you go, you know what? I'm coping better. That's a really good thing. And so that's a new thing we've implemented that we're spreading out to the community in Hamilton County, and we're excited about it. The other thing that I want to mention today, because it's really about community health. So the Medical Society, TMA, and AMA are professional organizations, and specialty societies are really important, but we're the organizations that represent all aspects of medicine. I have a sign on my desk, and this is what it says. You can practice medicine in Tennessee because 67 members of the General Assembly say you can. It takes 50 senators or 50 representatives or 17 senators to make anything happen. And sometimes the things that happen are a mess. The legislators have one patient who had a bad outcome or a bad experience, usually in a rural area. The way our state is laid out, rural communities have more influence in the legislature than the metro areas do. So they're more likely to have one patient with a bad outcome. And so usually the thing is, well, I'm going to keep that from ever happening by passing a law, and I'm going to make all doctors do this new thing. And most of you probably don't have any room in your practice to do very many more new things. An example is a few years ago, a parent lost a newborn. So the solution was we were going to require all doctors involved in the care of that episode to teach the parents infant CPR. Obviously, there were a lot of really unworkable parts about that. And so we worked really hard and got the whole thing changed. So parents now get information about infant CPR, but you can't ask the pediatrician or the OBG or the anesthesiologist who may have stepped in. All of them would have been responsible for teaching the parents CPR. So a lot of stuff that's kind of crazy happens. Last year, for instance, with TMA, we reviewed there were 1,467 pieces of legislation introduced in the General Assembly. Organized medicine tracked 248 bills. There were 248 bills that could impact how you all provide medical care. Kind of blows your mind. They significantly amended 13 of those and made the bad stuff from happening. They outwardly defeated 11 egregious bills, and they passed 7 bills that we hope would make it easier for you to practice medicine. So some of the things we've done are passed the Provider Protection Act that went into effect a couple years ago that limits the number of times insurance companies can come back and make massive changes in your insurance contracts each year. And they're supposed to tell you exactly what it was they changed and where you can find it in your contract. Instead of saying, hey, we changed something, find it in the 600 pages of information you'll find on our website. So part of what we're just trying to do is make it easy for everybody to practice medicine in Tennessee and provide great patient care. So here's my contact information, and Tracy, I guess most of you know Tracy, knows how to find me. We have an office on East 3rd Street, which is also the headquarters for Project Access and our medical foundation. And so I think the word I would say is, I hope you know that as you take care of patients every day, you're not alone. There's a whole group of organizations and people out there who are trying to fight for you and trying to make it easier to do what you do to take care of patients, because we know your heart, we know your stresses, we understand your calling, and we share that calling in that we want to enable you to do what God's called you to do. I faint at the sight of blood. It's really kind of terrifying. And I absolutely could not do what you do. But I can figure out how to write a piece of legislation and how to talk to legislators and how to start programs and keep them running. So that's pretty cool. You know, each of us does what we're gifted to do. And I honor you for the gifts that you display every single day. I honor you for the patient care. I honor you for taking the time to learn some cutting-edge information. And if I can't think of few things that could be more transforming than helping a patient save a limb. I just think it's an extraordinary work, and so I just want to thank you for what you do in this community. And Dr. Lasar, thank you for inviting me. And I don't know that I deserve your kind words, but I am moved and inspired by them. So thank you. Okay, guys, that was pretty good. 4:34.
Thank you, Ray, very much. I think you're wonderful,
Well,
and I appreciate you closing our session. You can see why I chose her. It's very simple, and I appreciate all the hard work she does for the entire medical community here. I do feel very privileged to practice in this area. It's something I love to do every single day. And I want to thank all the vendors who supported this conference, especially CSI and BD for being presenting sponsors. They did give us or grant us 8 hours of free CME each. That is adjudicated through the Tennessee Medical Association. I want to thank the VIC team that supported this process. I also want to thank this year Tracy Lassar. I forgot last year and got in trouble, by the way. But I would not have done this program without her. She has been the organizational backbone for this program, and I want to thank her for that. And I want to thank the speaker I want to thank the audience, for taking your time out of your day to actually be here and try to learn about things that are affecting our community, kind of where the vision is, where we see the healthcare going, and how we can actually start to impact that now. And I just appreciate your time here. Lastly, expect an email from Tracy regarding your communications about this program. I want honest feedback. We want to continue to try to make this better, and that link will then connect you to your CME. So at this point, I'd like to officially close FACES 2022, and I thank you all for attending.